Good morning. We are going to talk about med administration now. One of the things that is very different in pediatrics than adults, getting kids to take medicine. Everybody should have the experience of giving a 2-year-old toddler some Tylenol. So you do still give meds in clinical. You only get one med day, but you do still have the opportunity to give meds. So be thankful. A lot of, like even the on-campus program, they don't give medications in clinical anymore. So there are some meds that you can't give in clinical. Of course, you can't give blood or blood products. You can't give chemo. Some facilities limit IV push meds. Any meds that have to be double signed, that have to have 2 nurses' signatures, you guys can't give. But PO meds is the biggest delight about pediatric med administration. So we're going to talk a little bit about the rights of 8 rights of pediatric medication administration. Now, I think you guys learned 5 rights, maybe 6 rights, and the first 5 rights are the same ones: the right med, the right patient, the right time, the right route, and the right dose. But you also have to have the right documentation. Parents and patients have the right to be educated on their medication, and then they always have the right to refuse. So you need to know those 8 rights. And I've got my big screen back, so I think we can do the PowerPoint and the chapter at the same time here. Alright, so I'm going to try to keep up. Things that we're going to talk about IV med administration. We're going to talk about med administration through a G button. We're going to talk about oral. We're going to talk about otic. We're going to talk about eye creams and eye drops. So lots of information here. We're going to talk a little bit about dose calculation. That's more in your the math module, but we do talk a little bit about dose calculation here. Alright, so you've got pharmacokinetics and pharmacodynamics. This should be a review from your pharm class. So I want you to kind of go through each one of these little concepts in action and remember the definitions of pharmacodynamics and pharmacokinetics. The biggest thing with kids is the pharmacokinetics, because everything is weight-based. So based on your weight of your patient, absorption, distribution, that's all affected by the weight of your patient. Patient identification, of course, you know that's a big national patient safety goal, #1 goal, and making sure that you improve accuracy of patient identification. Make sure you always ask for 2 identifiers, name and date of birth. If you can ask the child and he can answer you, that's great, but always verify with your parents. Alright, some factors that might affect absorption and medication in children versus adults. Of course, we talked about body weight. Slower gastric emptying, so things hang around in the belly longer in kids. Intramuscular absorption, of course, they have smaller muscles, less options for us to use. Sub-Q, they have less fat, so we have less tissue to use for sub-Q injections. And topical absorption. Okay, with topical absorption, you've got to be very, very, very careful, especially with infants, because their skin is so permeable. Cortisone cream, hydrocortisone, a lot of times that's how we treat eczema, and you don't ever want to put that in the diaper area or on the face of an infant, because that is absorbed really quickly and really easily, and absorption through the skin, that medication gets in the system, and those are steroids. So be careful about that. Never on the face, never in the diaper area. Okay. Alright, in the chapter there are, of course, all of the boxes are important. Here are the 5 rights of medication. Of course, you need to add those other 3 on: the right documentation, the right to be educated, and the right to refuse. And this just goes over what you need to verify for each one of these rights. You need to make sure that you have the right med, make sure you have the right dose, the right route. You know, you hear all the horror stories of things being given IV that are supposed to be PO, and so just double check yourself. Now, one thing that this does talk about is BSA. And just a disclaimer, in this course, everything is fair game as far as exam material, unless I specifically say we will not be tested on, you will not be tested on that. BSA, body surface area, you will not be tested on. Okay, so can you skip that? Of course you can. All right, we're going to come back to developmental concerns here in just a second. Let's go back over to the PowerPoint. Some more things that might factor in with distribution: higher percentage of body water. Kids do. They have a faster metabolism, so things might be metabolized a little quicker. One thing, if they're under 6 months, see, it talks about liver immaturity. If they're under 6 months, there are certain medications that you shouldn't give them, one of which is ibuprofen. The liver's just immature, and it really doesn't do anything because that first pass elimination, it just all goes through. So if you have a parent that has given Motrin and you say, oh no, not less than 6 months you can't give Motrin, tell them not to panic. It's not going to hurt the child. It's just not going to work. So keep that in your brain. Immature blood-brain barrier, especially neonates. Everything passes through that blood-brain barrier. Say that 3 times fast. So you want to be careful. CSF toxicity can happen quickly, or CNS toxicity can happen very quickly since everything passes. That's also this is a side note, that's also one of the reasons why if you have a newborn, a neonate that has fever, you're almost always going to end up doing a lumbar puncture because they want to look for meningitis because things pass through that blood-brain barrier pretty easily. All right, we are going to go over these questions because the ones in this PowerPoint are pretty good. The nurse is administering amoxicillin orally to an infant with a bacterial infection. Which of the following physical factors might affect the absorption of this medication? Now remember, we're doing it PO. So, slower gastric emptying, vasomotor instability, decreased perfusion, or lower percentage of body water. Okay, A is your correct answer. Since everything empties a little bit slower, it might affect the absorption of amoxicillin. Now, fortunately, we take that into consideration when we prescribe it. So, again, based on body weight, based on the fact that they can empty things slower out of their gut, they adjust for the doses on those. All right, we talked about increased metabolic rate. Kids have a awesome metabolism, so things might get metabolized a little faster. All right, some developmental issues. All right, so you need to figure out why are we giving this drug. Now, when you do your med sheets, one of the columns that you'll see is what this drug is being given for. It's not necessarily going to be the labeled use. A lot of meds are used off-label with pediatrics, so we need to figure out why is my kiddo getting this medication. What they're going to experience, what's expected of the child, because if you have a 2-year-old toddler, you can expect some resistance most of the time. Now, I always ask parents, I say, will they take this medication better from you or from me? How are they at home with medication? You always want to know what you're up for, okay? Sometimes you'll be surprised, most times you won't. If they're bad med takers at home, they're probably not going to suck down that Tylenol out of that syringe for you. So, involve your parents. Now, I think we talk about holding and positioning here in just a second. If you can help it, let your parents be the good guys, okay? If you've got to hold down a patient and give them medication, see if you can't find somebody else to help, because mom and dad need to be the good guys, okay? All right, back over to the text. All right, take note, always administer medications pretty quick. assist the child in holding still using a comforting position. So again, if you have to position or hold, get you some holding help. All right, so now we're going to talk about determining doses. Now, this will be the big proportion of your med test. I was going to say drug test, but that wasn't quite right. Your medication administration test is going to have a lot of body weight dose determinations. So we're going to kind of walk through this. You're going to have math on each one of your exams. You're going to have to know formulas. We talk about an IV fluid formula here in just a few minutes. The first exam, I'm going to give you the formula on the exam. The second and the third exam, you're on your own. You got to memorize that formula, okay? And it's weight-based, and we'll go through it. There is a little bit of confusion sometimes in that calculation, so hopefully going over it like this is going to help. But for every medication you give, you're going to have to figure out if it's a safe dose or not, okay? So here's your steps. You weigh the child, okay? Always convert to kilograms. So you're going to have kilograms to start with, okay? Then you check your drug book and you say, okay, what's the safe dose range? And you're either going to get something like is listed here, 10 to 20 milligrams per kilo of body weight. Now, one very important thing that they leave out here, you need to make sure that if it's a per dose calculation or a per day calculation, they're very different. Okay, so whatever it lists in your drug book, in your drug reference, that's what you need to base your answer on. And if that doesn't make sense, example. So gentamicin, 10 to 20 milligrams per kilo per dose. That's a little high, I think, but well, let's go with something I know. Rocephin, ceftriaxone, 50 to 100 milligrams per kilo per day. So if you have a patient that's getting so much, and your question is, okay, this patient is getting 500 milligrams per dose, Q12 hours, you need to take that 500 milligrams and multiply it by 2 to get your daily dose. You want to make sure you're comparing apples to apples. Okay, that is one mistake that a lot of students make. They get a per dose safe dose range from the book, and then they have a per day safe dose in the question. So make sure your per dose per day, make sure they match up. All right, a lot of times you're going to have a range, like they list here, 10 to 20 milligrams per kilo. So you want to calculate the low dose and the high dose, and then calculate or see what your kiddo's getting and see if it falls within the range. If it does, it's a safe dose. If it does not, it's not a safe dose. Now, if it falls below, it's still a safe dose, but it's a non-therapeutic dose. Okay, so there is a difference. So say your ending low end of the range was 500 milligrams per day, and your child was getting 480 milligrams per day. That's a safe dose, but it's a non-therapeutic. Okay, so the answer to that, is this safe, would be yes, it's safe. Okay, so that's determining doses. You're going to be figuring that every day you're in clinical for every one of your meds for your patients. Now you know how I stress the developmental issues. So here it is broken down. Some things to look at, nursing interventions at each stage of development. So I would read through that box. Alrighty. Another question. Oh, we got a math question. Perfect. The safe dose of medication is 10 to 20 milligrams per kilo. Safe dose. What would the nurse calculate as the low safe dose for a child who weighs 40 kilos? So you take your 40, you multiply by 10, and you get 400. That's your low safe dose. Okay, your range, going back, 40 times 20, 800. So your range is going to be 400 to 800 per dose. All right, remember BSA? Not going to use it, so we're going to skip right through those slides. And then we're going to talk about some different forms of oral medications. Now, oral medications come in capsules, tablets, ODTs, oral disintegrating tablets, isn't listed on here. Syrups, elixirs, suspensions, those are all kind of the same thing. They look the same, okay? Powders are reconstituted sometimes into oral medication. Most of the time they're reconstituted into IM or IV medications. Some other forms of medications, you have inhaled powders and aerosols, an inhaler, like a Pro-Air inhaler, albuterol inhaler, aerosols. Powder inhalers, they do have, I think Advair is a powder inhaler where the little roto disc, you pop it and you inhale the powder, or the child inhales the powder. Those are kind of weird. Topical, you have patches, you have creams, ointments, lotions, drops. You even have some, we talked a little bit in one of I think the pain module about like topical ibuprofen. They can compound those into a topical cream for pain relief. And rectal suppositories. If you have a patient that's vomiting, or if they're NPO for a certain reason, then suppository is your way to go. Not everything comes in suppository form. Tylenol does, ibuprofen does not. So, got to make sure it comes in a rectal form. Alright, body surface area again, we're not going to address. Alright, so talking about oral administration. So you have to be careful. A lot of parents, if you give them the meds to give the child, and if they take it better from the parents, that's certainly an option. But a lot of times the way that they give it scares me to death. They'll tilt the kiddo way back and squirt it in their mouth, and the kid's gagging. You have a very, very, very high risk of aspiration with little ones. So teaching will be very important here. Sit them up. Go right down the side of their jaw with a syringe, a little bit at a time. If you put it way far back there in the back, like back by where their molars will soon be, you know, a lot of times they can't fight it, okay, and so they have to swallow it. Blowing in their face, you do not do that, okay? If mom opts to do that, I would just do some teaching. Say, Mom, you know, when you do that, they take a big deep breath. They might suck that medication down to their lungs. Be careful doing that. Okay, you'll see it done all the time. You'll see parents hold their nose. Again, it increases the risk for aspiration. Okay, so do some teaching. All right, ways to give oral meds. All of these, well, let's see. Yeah, I think those are all pretty good. What you don't want to use is you don't want to use just a regular spoon, okay? Those are very inaccurate. You can look at spoons and, you know, a teaspoon versus a teaspoon, the volume in those is a lot different. So make sure you use something that is actually measured or calibrated, okay? Another good teaching point. A nipple without the bottle, okay? That's an option as well. Do not let the parents or teach them not to put the medication in liquid, okay, or in the bottle. 2 reasons, well, probably more than 2 reasons, but the 2 main reasons is if it makes the liquid taste bad, then they may be very unlikely to take that liquid again. And and I learned this lesson the hard way, I'll tell you how. If you put a tiny bit of medicine in a lot of liquid, you've got to drink all that liquid. So one time we had an overdose patient, and with an overdose patient, one of the things you do is you administer charcoal. Well, charcoal tastes and looks just like you think it does. It's black and it's thick, and I think they do try to flavor it a little bit, but getting a 3-year-old to drink something black and thick, not going to happen. So what did I do? Mom says, oh, she loves chocolate milk. So I got a whole container of chocolate milk, mixed that charcoal with that chocolate milk, and there is no way that that child was taking that whole thing of chocolate milk. So just be careful and teach your parents those 2 reasons. You know, you don't want to put your medicine in a bottle of fluid, a formula of juice, anything like that. Syringe is probably best. There's great positioning, and see how they're going down right, pretty much to the side of the mouth. Some kids take medicine great, but yeah, sometimes it can be quite a challenge. All right, as far as taking crushed tablets or capsules, make sure if you have a medication that comes in capsule form only, make sure it's crushable or openable. Some of these medications are time released, and so you can't really crush them or open them up and sprinkle them on applesauce or whatever, because it affects the absorption and the metabolism of the medication. Same thing with J-tubes or G-buttons. If it's a pill form, make sure it's okay that you crush it, and you can crush it and mix it with water and put it through their G-button. Now, I hope that a lot of you get to experience giving meds through a G-button. We're going to talk a little bit about that. Powdered medications work well. You can mix them through with water. You don't want to mix them with a lot of water because you don't want to fill up their little tummies with a lot of water. A lot of parental involvement with G-buttons. Parents are, they're the ones giving meds at home. So ask mom, how do we take, how do you do meds at home? Some parents flush between each med. Some people don't. Some people flush before and after all the meds. Some parents don't. So make sure that you know their routine. The only time that you might want to, one of the things that you might need to check is, okay, so if I put this medication in and then this one after it, is there going to be a precipitation? Okay, so if it clogs things up, then you want to flush water between each med. Okay, and you might want to check your facility's procedure too. They might require you to flush a little bit of water between each med. So make sure you know what your facility does if you are given the opportunity to do a G-button med. Okay, and here's just those same guidelines. Make sure you do flush after. Verify placement of the tube. That's a good guideline. If you've got a G-button, normally those aren't going to be dislodged, but if you've got like a feeding tube and you're giving meds through, you need to make sure that you verify your placement of your tube with the initial placement and with each med administration and with each feed for that matter. And take note, of course, parental involvement is key here. Rectal administration, suppositories. We do give our share of suppositories, especially Tylenol suppositories. So it just kind of goes over some guidelines. Do you have to lubricate before the medication? Most of them are pre-lubed, but I always do anyway. So lay them on their side. You can lift their their leg up. If you wish you could see me. But if you lift their leg up and kind of put it over the other leg, that kind of opens things up and it makes the insertion a lot easier. All right, eye drops. Let's talk about eye drops. Good hand washing for eye drops, because and teach your parents this. A lot of times we're giving eye drops for things like pink eye. Okay, so you don't want to pass that around. So make sure you wash your hands. Make sure you wear your gloves. Don't touch the medication to the eyelid itself. If it's a drop, you can drop it in the inner canthus there, and as the patient blinks, it's distributed. If it's an ointment, which is just, to me, horrible about putting in eyes, but a thin ribbon across the bottom lid is how you want to administer that. Here's some teaching guidelines about eye medication. These are all fabulous. Okay. So make sure you read through this. There's some pictures. All right, otic administration. There is one little nuance I want you to remember about this. Kids get a lot of eardrops for swimmer's ear, for perforated eardrums. So you will be doing some teaching to teach parents how to do these eardrops at home. So remember the age of 3. Okay, if they are younger than 3, you pull the outside of the ear down and back. If they're over 4, you pull it up and back, and that straightens out that ear canal, whichever way it needs to be straightened, in order to get that medication where it needs to be. Okay, so remember that little concept mastery alert there. Nasal administration. Okay, nose drops. Nose drops, nose sprays. Nose drops, one thing I want you to remember, infants are obligate nose breathers. So go slow and do one side at a time. Okay. This gives you, there's some pictures. Pulling their little ears up. Alright, so then let's talk about IM administration. Unfortunately, you got to give shots to babies. Some IM injection sites. If they're younger than 7 months, we want to use the vastus lateralis. Okay, that's the leg. That's the best place to give them if they're younger than 7 months. If they're older than 7 months, between 7 months and a year, you can still use that site, but they push more towards the ventrogluteal. And on the left there shows you kind of how you find that spot. Dorsogluteal, dorsogluteal, they don't recommend using hardly anymore at all because of the sciatic nerve. And then deltoid, you can use deltoid if that muscle is developed enough in your child. There is a table in the book right there that talks about volume. Okay, you do want to adhere to the volume restriction. You don't want to give any more than 2 mils in any site in your children. Okay, 0.5 can be given if you have a medication, like say you have to give Rocephin, and you have 1 mil of Rocephin that you need to give to an infant. Split those vaccines or split those shots up. Give 2 shots. You don't want to give any more than 0.5 mLs. Okay, so you need to know this information here. Also, the gauge and the length of the needle. Make sure your needle's long enough to get to where it needs to be. In a school-age kid, you probably need a 1.5-inch needle. And then make sure that it is big enough to get your medication through. One of the things I think about is bicillin. If anybody has ever given or witnessed bicillin given, bicillin is a form of penicillin that looks like shaving cream. And unfortunately, it pushes like shaving cream out of a needle. So you want to use, even though we're trying to use the smallest needle possible, a 25 gauge is not going to work with bicillin. I'll tell you that right now. 22 gauge at least with bicillin. So just keep that in the back of your head if you ever have to give bicillin. Everything else is pretty liquidy and pretty, the same consistency for the most part. But bicillin is one that you need to think about your size, your gauge of your needle. All right. Sub-Q and intradermal. Intradermal, let's see, what do we give intradermal? We do TB testing intradermal, sometimes some allergy administration, allergy med administration, or allergy testing administration is done intradermal. Not one we use very often. Intradermal, you just go right into the skin and you just inject, and you're going to make like a little wheel, and it'll bubble up, and that's how you know you do it correctly. Very, very, very shallow. Okay, like it says 5 to 15 degree angle. Just go barely under the skin. Sub-Q, you want to go 45 to 90. I go about 45. And you want to make sure that you've got somewhere with some sub-Q tissue. Again, children don't have a lot of sub-Q tissue, so finding a place to do that is sometimes a challenge. All right, when you're doing all of these poking and prodding on your poor little children, you want to make sure that you keep those atraumatic care principles in the back of your head. Comforting positions, parents need to be the good guys, educating the parents, okay, doing your 5 rights, making sure you're giving the right med, right dose, right route, etc. Okay, using those topical anesthetics, so cold spray or IMLA to numb the area that you need to inject. And that really goes into effect when you start to talk about IV therapy. All right, sometimes IV therapy is necessary, okay? And when you're starting IVs, pain control, distraction, lots of hold help. Lots of things can be done to reduce the trauma associated with an IV. Okay. One thing to remember, another thing to remember, if you are going to have to draw blood and you expect that you're going to have to give medication or IV fluids, go ahead and ask your care provider for an IV order. It's much more humane to only have to poke on a child one time. Okay. All right, some things to think about when you are thinking about equipment. Make sure that you're using the right size needle, the age and developmental level of the child. How are your kids' veins? Are they a hard stick? Do they have to use the smallest catheter possible? If they're a bigger child and they've got a really good AC and you can put a bigger gauge needle in, then think about that as well. Okay. And what kind of medication are we given? Are we given lots and lots and lots of fluids very fast where we need a good big IV, or are we just given some IV antibiotics? So think about those different things. Make sure you gather all your equipment up beforehand. Ask the child, you know, where do you want, this is where we can, these are your choices. Which side do you want to use? If you've got a teenager, think about texting. You know, are we going to tie up your phone hand? Different things like that will kind of give your patient a little bit more autonomy. Make sure you've got good pain relief going on with cold spray or with EMLA. If you have one of those cool little vein finders, those are awesome. You can use those to minimize your number of sticks. All right. As far as location, there is a picture in the book. Let's see if I can find it. That has location of veins in it. Sometimes they put these pictures in places that they don't really belong. So let me see if I can find that picture. Sorry, making you dizzy probably. Here it is. Okay, so here's the different sites that you can use. Now this is a big kid, and they do point out scalp veins on here. I wouldn't use scalp veins unless they were my last resort in a child this big. Babies, okay. Scalp veins, last resort, they scare parents. Parents see that IV in their baby's head and you know, they think all kinds of bad things. So I would use that as a last resort. Hands are great. Feet are great if the patient's not walking, or you know, if they're going to be immobilized for a long time. But those are the main sites that we use. This kind of lists every single site. So there's some ideas about sites. Okay. Question: in the following statement, is the following statement true or false? Nurse is assessing the veins of a 5-month-old and correctly chooses the baby's foot. True. You can use a foot in a 5-month-old. Those are actually very good veins. Okay. All right. Most locations or most facilities have a 2-attempt rule. I personally have a 2-attempt rule. I'm only going to stick a child twice, and sometimes only once. If I stick once and am not successful, then I usually will seek out someone else to help us. Now, a lot of places do have an IV team that you can call if you're having a difficult time finding an IV site or getting an IV stick. Lab will come and draw blood for you if you, if you're having a hard time getting lab. But don't continually poke on your child. If you feel like you can't get it and you look and you say, my skills aren't that great, then call somebody else. Okay? Minimize that trauma. All right, you want to make sure you assess the insertion site at regular intervals. If it's a running IV, you need to assess it at least once an hour. Okay? If it is just a lock, a hep lock or a saline lock, you need to assess it every 2 hours. And you're going to assess for things like redness, swelling, coolness, and swelling. A more realistic assessment of an infiltration is cool and puffy. Red and puffy means inflammation. Cool and puffy means that it may be infiltrated with IV fluid. So make sure you assess that site. It says secure line with a minimal amount of tape. Don't know that that always happens. We use a lot of tape in pediatrics. So make sure you secure your line, and that's the key point there. Secure your line. Okay? You only want to have to stick a patient one time. All right. We are not going to talk about nutritional support in this section because there's a whole section on nutrition, but I do want to go through a couple more things in the chapter. You might run into, in addition to like a peripheral IV, you might run into some central lines. Okay, so some different types of central lines it does list here. PICC lines are very popular. If you've got a patient that's going to go home or is going to get long-term antibiotics, you might see a PICC line inserted. PICC lines you can draw blood from. They're treated just like a central line. Okay, we do have a PICC line team, I believe at Cook Children's, so a lot of places probably have that. But if you ever get a chance to go with your patient and see a PICC line inserted, please do. Central venous catheters come in many different forms and fashions. Like a triple lumen CVC, sometimes those are put in with traumas. They're more short term. If you have a patient that is going to have long-term TPN or things like that, then you might see a Groshong or a Hickman or a Broviac. Metaports, portacaths, our hematology oncology patients usually have those. That's a device just under the skin. If you haven't seen one of those, you might want to Google some images of them. They just sit right under the skin, and they are usually up on the upper chest wall. Now, I've seen some like under the rib cage. If you have a very skinny child, they'll put them where there's a little bit more fat, but those have to be surgically implanted. All right, and then this just goes through starting an IV. Of course, making friends with your patient. Child life has got to be involved, or somebody to distract. That little guy's cute. Somebody to distract your patient. This, for us old-timers, that's a Buretrol. I'm not even sure if they use Buretrols anymore because they do use syringe pumps and a more controlled IV flow. But that's a Buretrol, and we used to, you'd put like an hour's worth of fluid in there and then lock it off at the top, and then you would just make sure that your patient doesn't get, too much too fast. So it's called a Buretrol. It's probably in the museum for nursing products now. All right. IV fluid administration. Okay, I told you we were going to talk about this. We're going to hit on this real quick. There's your formula. Okay, so if you have a patient that you need to know how much IV fluid am I going to get, or is this patient going to get in a day, you take the weight and you divide it up. 10 kilograms, 10 kilograms, and then everything else. So say you have a 25 kilogram patient. We're going to do some math. 25 kilogram patient. You take the first 10 kilos, 10 times 100 milliliters per kilo. So you would get 1,000. So put that over here on your right-hand column. Then you have your next 10 kilos. So remember we said 25 kilos. So the next 10 kilos times 50 mLs, that's 500. So you've got your 1,000 plus your 500. Then you've got 5 kilos left over. So you take your 5 times your 20 per kilo for anything over that, and you get 100. So you've got 1,000, you've got 500, and you've got 100. Add those together, you get 1,600 mLs per day for your 25 kilo child. Now, in order to figure out how much per hour that is, you take your 1,600 and divide it by 24. So that would give you an IV rate for that patient per day. Now, that's not taking into consideration any PO fluid. That's just your IV fluid. Okay, so here's an example. Another example. 100 mils per kilo for the first 24 hours. So if you've got a 7.4 kilo kid, okay, so this is a little different. This is good. 7.4, you take all 7.4, because that's all you got, times 100, and it equals 740. Okay, that's your daily requirement. Divide that by 24, and there's your rate. Now, there are 3 instances where you do not round. You report in a whole number in pediatric med administration. IV rates, daily calorie count. There's one more. I'll think of it here in a second. But those 2, if you're going to report in how fast an hour or how many meals an hour, always has to be a whole number. Okay. All right, there's a couple more examples. I'm going to let you look through those. I think there's some examples in your practice math information. One more little note. When you are weighing diapers, remember intake and output. 1 gram of weight in the diaper equals 1 ml of fluid. Okay, that will become important in clinical as well. All right, I'll let you read through that. When you take out an IV, there's some helpful hints to practice atraumatic care by taking out your IV. Again, we do use a lot of tape, so you might need a lot of scissors to get that kiddo out of his IV. All right, and that will do it for today for med administration. I am going to put some practice math med administration problems up, so look for those in the next day or 2.